Hi there. In the last lecture, we talked about follow-up rates and what was considered an acceptable follow-up rate. Today, we're going to talk about the types of outcome variables that you would want to measure. And we had suggested that at the very least, you would want to measure whether people are continuing to use the substances that are the focus of treatment, whether they've relapsed or whether they're abstinent. So you want to measure substance use. You want to measure dependence symptoms and dependence severity if people have relapsed. You want to measure substance-related problems because that is often a goal of treatment. And you want to measure psychosocial functioning. These are the main four groups of variables. And I'm going to give you some examples of how these measures are distributed over time in a group of patients who were exposed to the three conditions in the marijuana treatment project. If you remember, MTP randomized 450 research participants who were chronic marijuana users to three conditions: a delayed treatment control group on the top, a group that received 2 sessions of brief motivational treatment, represented in the middle, an extended treatment group that received up to 9 sessions of motivational and treatment and cognitive behavioral therapy. You can see the way that their outcomes were distributed according to a method of evaluating their substance use, in particular, in this case, the days on which they smoked marijuana across time. So each follow-up period included an interview where day by day they retrospectively reported what they were doing in the prior weeks. And so you could get a continuous measure of every day since the last follow-up. And that's called a timeline follow-back assessment, which we're going to be talking about a little bit later in terms of how you measure these variables at baseline. But today we want to talk mainly about substance use, dependence, and problems as outcome measures. So here's the distribution. It shows that on a continuous basis, the three treatments led to quite different results. And one way of summarizing the data is to just condense the weekly reports into averages for the main follow-up periods. So at 4 months and at the end of treatment and at baseline, you can make a comparison of the percent days that people were either using cannabis or were abstinent. It's also important to look at not only the averages for the people who you followed up, and in the case of the MTP project, it was like over 80% at most of the follow-up periods. But you want to, in some cases, do an intention to treat analysis, which means that you assume that people who weren't followed up may have relapsed. And that's a worst case scenario. But even assuming that those people were using marijuana at each of the follow-up period, you still get significant differences between the groups, which suggests the robustness of the findings. Here we have 4-month follow-up data in terms of how much people were smoking and how many days they were smoking or abstinent, but whether or not they were abstinent at that follow-up period. And what we found was that most people had reduced if they received treatment, but they didn't stop. So it was only about 22% who claimed that they were totally abstinent in the 9-session treatment. And it was only about 8.6% in the group that received 2 sessions. And very low abstinent rate, close to zero, 3.6% in the delayed treatment group. So here we have, as a single outcome, abstinence versus relapse. And that is often a useful measure. Now, what we're going to be suggesting is that you look at a variety of different outcome measures. And to the extent that they each corroborate one another, we can put greater faith in the findings. Here again, we see big differences between the 3 groups, which suggest that no matter which way you cut it, the more extended treatment was better than the 2-session treatment was better than no treatment. Here's a mapping of the number of dependent symptoms at baseline and follow-up. And here, dependent symptoms are measured using the diagnostic criteria for a cannabis use disorder. And the more symptoms, the greater the dependence. Here again, you find at 4 months a reduction in the total number of symptoms and in the severity of dependence, which provides another outcome measure that could be useful in demonstrating that one treatment is performing better than another. Another way of looking at outcomes is in terms of the number of problems that people report, whether they wake up in the morning and they feel like going back to bed or they get out and go to work, whether they have a problem taking care of ordinary activities, like they're taking care of their kids or going shopping, whether they feel tired or depressed or lack energy. All of these types of problems can be summarized in a scale, in this case called the marijuana-related problem scale, which adds up the number of problems that people report. And you can measure that at baseline and at 4-month follow-up and at subsequent follow-ups. And here again, it's a way of looking at people who have either relapsed or people who have remained abstinent in terms of the types of problems that they report. Another way to verify whether or not the self-report information is accurate, because it's often considered skeptically by people who are looking at treatment outcomes, is by looking at the results of urine screening. And here, what we have been able to show is that at baseline, the urine screen results were low in terms of demonstrating abstinence. So if the time window for a marijuana urine screen is a few days to a week, some people will come up negative, even though they need treatment. But the number of people who screen negative, according to a urine screen, is much higher in the groups that received an intervention. And here again, we get objective verification of self-report information. One way of looking at that to convince the skeptics is to compare what people said in their self-report questions to the urine screen data collected at the time they were interviewed at the 4-month follow-up. And if you look at the right-hand column under the total for urine screen data, 22.9% of the follow-up sample was negative on a urine screen. 77% were positive, that at least they had smoked during the prior few days up to a couple of weeks. But still, 22%, almost 23%, were negative on their urine screen. Now look at the bottom row under the total, under the self-report data. 22% or 22.3% reported that they were abstinent, and 77.7% reported that they were smoking at 4-month follow-up. Those are virtually identical proportions to the urine screen results. But there are some discrepancy. 5.6% were negative on their urine screen, but they reported smoking in an interview. And that could be because the urine screen was not accurate. So sometimes a self-report measure can actually tell more than an objective measure. But we also found that 5% who were positive on the urine screen said they were abstinent. So they could have been lying. So about 10% of the urine screen results were inaccurate, but the good thing is that the self-report data were corroborated by the urine screen data. That's it for today's talk about how to measure outcomes, and we're going to go on and suggest other studies that could be served as good examples in subsequent lectures.